Hey y'all, this is Chelsea Epling from IMED. This slideshow is going to be a brief review of PA catheters and their use, and then just for fun, we're going to dig into how you can diagnose and differentiate shock states using this catheter. I put this together because PA catheters, also known as Swan-Ganz catheters, really aren't heavily transported and tend to initiate the pucker factor when you hear that your patient has one. I'm hoping that after this presentation, some of your fears will be eliminated and that you'll have a better understanding of the diagnostic purposes. Because these seem to be the unicorn in the pre-hospital and transport world, it's extremely important that we're not only prepared for them, but that we understand how to utilize them. So I'm going to give you the down and dirty of our little yellow friend. First, take note of the little black lines that go all the way around the catheter. You want to be able to understand these as it allows you to know if your catheter is migrated during transport. Total length is 110 centimeters. So if you look closely here, one thin black line is 10 centimeters, two is 20, and so on until you get about 50. And 50 is going to be a thick black line. So moving on to 60 is one thick black line, one thin black line, all the way to 100 here when you get two thick black lines. If you're transporting this patient, this should definitely be one of the first things that you note on your assessment of the PA catheter. Different manufacturers do exist with some variations, but one thing that is standardized is the color of the primary lumens, as you see here. All pulmonary artery catheters have a blue proximal port, yellow distal port, and a red balloon inflation port. Your blue proximal port correlates with the right atrium and is used for cardiac output, CVP, and depending on your facility, push medications or infusions might be given. Some arguments can be made that if you're infusing critical med through this port, then checking a cardiac output, you'd be giving a push dose of whatever that medication is. So make sure to check with your agency's protocols before infusing any medication through there. The yellow distal port correlates with the pulmonary artery, and this is where you get your continuous waveform. Infusions definitely shouldn't be ran through here. The white port right here, I like to call the VIP port because you can run pressors or any other medication that you need as long as you want through there. The red port is probably the most important to note in your assessment. It is where you inject the air needed for the wedge. Now, this is a specialized syringe. It only allows you to insert 1.5 cc's of air, will not let you insert anything more, and it actually comes inside the kit. So when you're transporting this patient, you look closely here. If this is lined up, it actually makes an arrow, which will allow the air to go through. So when you're transporting, you want to make sure that this line is kind of off-centered here so that even if for whatever reason your syringe wants to inject air, it won't be able to. There's several different patient populations that can actually benefit from a PA catheter, and I'll let you read those for yourself. The major thing to note about PA catheters that's different from your typical central line is that these are for diagnostic purposes and not therapeutic. I'm a visual person, so we're going to draw a big green circle around diagnostic and a big ol' X over therapeutic. This image shows the waveforms of the pulmonary artery catheter and where the catheter is positioned in the heart respective to the waveform displayed on your monitor. So let me get a laser pointer here. In this first section right here, this is known as your right atrial waveform, also very commonly referred to as your CVP. Normal values here range from about 2 to 6. The next section is your right ventricular waveform. Normal values here are much higher with a systolic pressure of 15 to 25 and a diastolic of 0 to 5. Now I want you to pay extra special attention to this anacrotic notch that happens to be on the left. Moving to the pulmonary artery, this is the waveform that you should see at all times when you're transporting this patient. Actually, really, whether you're in the cath lab or the ICU, this is the waveform you want to see. Anything other than this waveform is not correct placement and would require intervention. Normal values here are a systolic pressure of 15 to 30 and a diastolic pressure of 8 to 15. Now we're going to look at this. It's a dicrotic notch on the right. Looks very similar to your A-line waveform. So when you have these two right next to each other, they don't look that similar. But if you're seeing them on your monitor, this is something that you can pick up on. If there's an anacrotic notch on the left, then that's in the right ventricle, and that's a big deal. That's a big problem. We've got to get that fixed. If it's on a dicrotic notch on the right, you're good to go. Right is right placement. Finally, over here, we reach our pulmonary artery wedge pressure, and this is what's going to happen whenever you press that air into the syringe or out of the syringe into the balloon. Your pulmonary artery pressure should be around 8 to 12. I'm sure some of you are wondering why knowing this is important. When as nurses in the hospital, we don't get to diagnose our patients, or as medics and nurses out in the field, our patient's already going to have a diagnosis along with his catheter. I just so happen to be one of those people that likes to really nerd out and know the why behind things. So knowing exactly how to use this device to tell me what shock state my patient was in was something that really interested me. If you plan on taking an advanced certification such as a CCP, FPC, CFRN, or even the CCRN, you should probably expect to see some questions asking you to be able to tell which shock state your patient's in based solely on just the numbers that you get from this catheter. I'm sure if you've ever taken an advanced certification, you've seen a question like this. And if you're anything like I was when I first started studying for advanced certs and really dealing with PA catheters in the hospital environment, you probably read this question from left to right. So let's try it that way. All right, your CVP is low normal, so think about what would make your patient dry. Immediately, my mind's racing of thinking of how these shock states affect the human body. It's possible they're in hypovolemic shock, maybe septic shock. Then we move on to the next value. That method makes it about 10 times harder than it has to be. How I've found that makes it a lot easier to determine what shock state your patient is in is to start with systemic vascular resistance. Starting with SVR cuts your options automatically in half. Normal levels for SVR are 800 to 1200. If your SVR is less than 800, you're going to be in a distributive shock state, giving you the options of septic shock, neurogenic shock, or anaphylactic shock. If the SVR is greater than 1200, the patient will either be in hypovolemic shock, cardiogenic shock, or shock related to a right ventricular myocardial infarction. Step 2 gets split into Part A and Part B because depending on what spectrum you're on with SVR determines the next value that you look at. When you have a low SVR, you will next look at the cardiac index. Normal range is from 2.2 to 4. If your cardiac index is high, you can stop right there because you've got a diagnosis of septic shock. If your cardiac index is low, you then have to look at heart rate. If the heart rate is low to normal, then your patient's in neurogenic shock. If you're tachycardic, then you're in anaphylactic shock. On the opposite spectrum, if your SVR is above 1200, the second step is to look at the CVP. If the CVP is low, again, you can stop right there because you've got your diagnosis of hypovolemic shock. If the CVP is high, you next have to look at the wedge pressure. If the wedge pressure is high, then you have cardiogenic shock, and if the wedge pressure is low, it's shock related to a right ventricular myocardial infarction. So let's look at that question again. Is the SVR low or high? It's low, so our next step is to look at the cardiac index. Is the cardiac index low or high? It's high. So your answer for this question would be septic shock. Feeling good? Let's look at one more for good measure. First, is the SVR low or high? It's high. So that means we have to look at the CVP next. So is the CVP high or low? It's really high. So we do end up having a third step with this question, and we have to look at the wedge pressure. Again, is the wedge pressure low or high? In this case, it's low. So that would mean the patient is in shock related to a right ventricular myocardial infarction. So all of that is great for testing purposes, but what if you're in the hospital, the back of an ambulance, or an aircraft with this patient? Sure, you can get all of your numbers from the screen, but what about the wedge pressure? The vast majority of patients only get a wedge pressure upon initial insertion of the catheter. The reason being is that every time you inflate the balloon in the pulmonary artery to obtain the wedge, you're putting pressures on the wall of the pulmonary artery. For anyone that's ever had an anatomy class where you actually get to lay your hands on a heart, the pulmonary artery really isn't much thicker than tissue paper, so it's best not to wedge. So now you're probably thinking, well, she just told me I had to have a wedge pressure to diagnose cardiogenic shock and shock from an RVMI. Here's the really cool thing. Look at this chart one more time, but notice how the diastolic values of the pulmonary artery is really close to the same reading for your wedge pressure. Use this value and you have no need to wedge. I hope that this has helped to alleviate some of the uncertainties that you might have about these catheters and that you have a better understanding of the diagnostic purposes of the PA catheter. Thanks for watching, and as always, stay safe.